joint configuration becomes abnormal, observing sudden changes in the joint angular motion, and assessing the ground reaction forces. Our results showed that the abrupt valgus and internal rotation, as well as peak vertical ground reaction force occurred at 40 milliseconds after initial contact. And in the second study, we also saw that the abrupt ATT reached 9 millimeter in 30 milliseconds after initial contact, which corresponds to the maximum ATT in intact knee. So together with previous studies that showed ACL was strained approximately 40 milliseconds after IC in simulated landing, ACL injury might occur within 40 milliseconds after IC. So if you look at the injury mechanisms, valgus collapse in combination with external rotation were frequently identified in simple visual inspection. However, it's been controversial if this is actually the cause of injury or simply after the ACL being torn. But our research shows that the immediate valgus motion occurred within 40 milliseconds after IC, and the internal rotation also occurred during the first 40 milliseconds. Then external rotation was observed, meaning external rotation occurred after ACL was torn. In addition, ATT started a little later IC and increased abruptly until when the injury might have occurred. These results suggested that ACL was torn by valgus, internal rotation, and ATT, and external rotation happens after ACL is torn. That is, knee in tort is just the consequences of ACL being torn. However, these studies only evaluated kinematics, which is a result caused by excessive loadings on the knee. So they did not evaluate forces and moments, which were causes leading to the kinematics. Therefore, to estimate knee joint moments from injury videotapes are required for understanding more detailed ACL injury mechanisms. So first case is one-leg landing. She suffered ACL injury on her left knee. And we analyzed moments as well as kinematics. And this is a moment graph, and this is kinematics. If you look at the moment graph, the initial peak of the flexion moment and the abduction moment occurred at 5 milliseconds after IC, which is induced by the impact force. In addition, sudden increases of the flexion angle as well as the valgus angle were also observed during the first 20 milliseconds after IC, meaning ACL injury occurred within 20 milliseconds after IC in this case, and the compression and valgus loading caused by the impact force is the mechanism here. The second case is a deceleration maneuver. She suffered ACL injury on her right knee here. And again, the moments and kinematics. First, initial peak of the flexion moment also occurred at 4 milliseconds after IC. However, the peak of the abduction moment occurred at 36 milliseconds after IC, which is induced by the inertial force of the upper body. If you look at the kinematics, valgus angle increased only by 6 degrees during the first 40 milliseconds after IC. However, which was increased by another 8 degrees during the next 20 milliseconds. Peak internal rotation angle was also observed at 60 milliseconds after IC, meaning ACL injury occurred between 40 to 60 milliseconds after IC in this case. And valgus loading caused by the inertial force of the upper body from sudden deceleration is the mechanism in this case. So we identified two possible injury patterns. One is compression and valgus loading caused by the impact force in one-leg landing, and another is valgus loading caused by the inertial force of the upper body from sudden deceleration in decelerating maneuver. Besides, rotational moment was smaller than the others, suggesting that coupled motion of internal rotation seems to be generated by compression and valgus loading. This motion was probably due to posterior slope of lateral tibial plateau. That is, axial compression makes lateral femoral condyle displace posteriorly due to posterior slope of lateral plateau, resulting in external rotation of femur, that is, internal rotation of tibia. Actually, ACL-injured patients have been reported to have greater posterior slopes compared to control. So based on these results, we proposed a new ACL injury mechanism. When valgus loading is applied, MCL gets taut and lateral compression occurs. The compressive loading causes lateral femoral posterior displacement due to posterior slope of lateral plateau, and ACL ruptures through ATT and IR. After ACL is torn, the primary restraint to anterior tibial drawer is gone, and the medial femoral condyle displaced posteriorly, resulting in external rotation of tibia after ACL is torn. So next, I'd like to think about the hip load for ACL injury. These are graphs of hip kinematics in the 10 cases, as same as knee kinematics. And if you look at the graphs, hip kinematics at initial contact were 20 degrees in abduction, 50 degrees in flexion, and 30 degrees in internal rotation. And more remarkably, they were so constant during 40 milliseconds after IC. If you look at the literatures about the risk factor, hip energy absorption and hip flexion angle and its angle velocity were identified as a risk factor for ACL injury. And some injury mechanism studies showed that the first one is the cadaver study. A restricted flexion of the hip caused ACL injury in simulated single leg landing. And video analysis also showed that ACL injured subjects' hip flexion and abduction were constant during 100 milliseconds after IC, whereas control hip flexion increased by 15 degrees. Our results also showed that hip kinematics were constant during 40 milliseconds after IC at abducted, flexed, and IR position. In this regard, Hashimi proposed hip extension knee flexion paradox hypothesis, which is the mismatch between hip and knee flexion in landing is the cause of ACL injury. In normal condition, both knee and hip flex together, whereas in abnormal conditions, knee is forced to flex, but hip is forced to extend, and tibia will undergo anterior translation. What's the reason for this paradox? In sagittal plane, upright or backward-leaning trunk position at IC might be the reason. Center of mass was positioned posterior to knee, and increased ground reaction force may encourage more knee flexion than hip flexion, acting to extend hip. In other planes, insufficient hip abductor external rotator strength or activation might lead to large hip internal rotation at initial contact. On the other hand, recent studies have shown that ACL patients have a limited range of motion of hip internal rotation. So hip may be locked at large hip IR position. To summarize, hip is relatively locked at the initial contact and cannot absorb energy from ground reaction force, which leads to ACL injury because of the knee was exposed to larger force. Then we also tried to analyze the no-injury situation. This is, again, not football, not handball, but football. But if you compare these pictures, they look quite same, but this is the injury situation, but this is no injury situation. If you think about the characteristics of defense motion in soccer, decelerating maneuver in one leg standing is it happens so often. And the common risk for these two situations are center of mass or posterior to knee, meaning posterior leaning of the trunk and relatively extended hip. So we analyzed 4 cases of no-injury situation in football. And these are knee kinematics. So these are injury situations as I showed before: valgus, internal rotation, and flexion. But if you look at the no-injury situations, it's the same that the knee flexes gradually. However, you only see little change in valgus and internal rotation. And this is hip kinematics. Again, in injury situation, the hip kinematics were constant. But in uninjured situation, hip flexes gradually, and hip is in externally rotated position at IC, and becomes internally rotated gradually. So to summarize, the kinematics in no-injury situation were that knee is flexed gradually, and hip is externally rotated at the initial contact, and flexion and internal rotation were observed gradually. So both knee and hip flex together, and in hip, it's also internally rotated, and this motion absorbs the compression force from ground reaction force. So to summarize, MBIM technique made detailed video analysis possible, and new mechanisms for ACL injury were proposed. ACL injury occurred at approximately 40 milliseconds after IC, and there were 2 possible injury patterns. One is compression and valgus loading caused by the impact force in one leg landing, and another is valgus loading caused by the inertial force of the upper body in deceleration maneuver. External rotation happens after ACL is torn. That is, knee in toe out is just the result of ACL being torn, not the mechanism. It seems that valgus loading and lateral compression generate externally rotated motion and anterior tibial translation due to the joint geometry, resulting in ACL rupture. Hip kinematics were constant at the abducted, flexed, and IR position during initial contact and at the time of injury. It seems that hip is relatively locked at the IC, cannot absorb energy from ground reaction force, and knee is exposed to larger force, which leads to ACL injury. Based on these results, I'd like to propose some tips for prevention. First, feed-forward strategy before landing is important, because feedback strategy, meaning prepare the for injury after landing, is too late. It takes 150 to 200 milliseconds, so it cannot prevent the ACL injury. Therefore, prevention should focus on before landing, such as pre-activation or brain education, and so on. Acquiring good cutting and landing technique is, of course, important. So knee should be flexed, and the knee valgus should be avoided. Hip should be flexed to absorb energy from ground reaction force, and hip internal rotation should be avoided. I'd like to acknowledge my bosses in Oslo Sports Trauma Research Center in Norway, Professor Waldberg, Lars Ingebretsen, and Dr. Torn Krosshag. I could do nothing without them. And I also would like to acknowledge my coworker in Japan. This is my department in Tokyo Medical and Dental University. Thank you for your attention.
Thanks, Hideyuki, for the nice presentation. I open the floor for the questions. Are there any questions? There's a question, Rod, at the back, please. So the microphone, whoever has it, please. Rod is in the middle there. Maybe you can come by the way, you're almost here, so come on the stage, so it's probably easier.
Thank you for a terrific presentation. The question that I have relates to what you said right towards the very end about the importance of the feed-forward mechanisms. At the time of initial contact,
As I showed, as I showed in the slide, if you look at the no-injury situation, the knee position is quite same, actually, in kinematics. But the hip position is different. So the hip is more flexed and more externally rotated. And so they are very prepared for the landing, so they can flex and they can internally rotate it, so that you can absorb the energy from the ground reaction force. That's the difference.
Other questions? It's a bit hard. Oh, yes, Philippe, please.
Thank you, Dr. Koga, for this very nice presentation. We, especially this new information about the hip, and more and more people are studying the hip. Do you have the same data concerning the ankle? Because I'm thinking about the handball, where the ankle injury and the way how the players are landing or walking, running. Do we have some data which can explain?
Yeah, we have data. So in all cases, because the center of mass was posterior to the knee, so they all get the heel contact first, then the foot is fixed to the ground afterwards. So the kinematics itself compared to the tibia, relative to tibia, is a bit different, but the motion was totally same. Heel contact, then internally rotated, then the foot is fixed to the ground. So you cannot avoid the energy from the ground reaction force.
Peter, please.
Hi. I enjoyed the talk very much. What role does the quadriceps play in all this? Does it have any role at all, pushing the femur back through the patella while all this is happening?
I doubt about the quadriceps drawer mechanism, because Hashemi also showed that if the quadriceps is totally relaxed, then ACL happens. However, if you have the co-contraction of quadriceps and hamstrings, then ACL injury could be avoided. So I think the quadriceps works as a stabilizer of the knee by compressing the knee. So I doubt that the quadriceps drawer causes ACL injury.
Well, while it's stabilizing the knee, it's also contracting, right?
Mm-hmm.
So there's got to be a posterior force on the distal femur through the patella.
How can I say? So in the situation where you see ACL injury, of course the compressive force comes from ground reaction force actually causes the ACL injury, because the compression force between the femur and tibia is not happening because of quadriceps not working. Yeah, I know that the quadriceps could pull the tibia forward, but in this case, I don't think quadriceps is the mechanism.
Well, it can't pull the tibia forward because the foot is fixed, but it can push the femur backwards, right?
Yeah, could be, but I'm not sure.
All right. Further questions, further comments? I think that doesn't seem the case, so thanks
Thank you very
for
much.
the nice talk.